applicant webinar. We're in webinar mode, and so we will proceed this way as we move forward. I'm Jackie Anderson, Senior Director of Grant Making at the Foundation, and I have two of my colleagues with me, Rena Singh, Senior Program Officer, and Evelyn Montero, Grants Management Administrator, who will be helping with some of the logistics today. A little in the program, we'll welcome our guest speakers, Dr. Stephanie Smith of Partners in Health, Renelle Walker-White, the Family Van, Rachel Plummer of Cambridge Economic Opportunity Committee, and Rachel Isaac of the Partners in Health. Next slide, please, Evelyn. For our agenda today, we will provide a brief background on the foundation, highlight why we've developed the program and its goals. We'll provide an overview of Problem Management Plus, the intervention on which this program is based. Then our guest speakers will discuss their experiences implementing Problem Management Plus intervention. We will then provide an overview of the training, technical assistance, and evaluation that the grant partners will obtain, discuss eligibility and the timeline for this grant program. Then we'll open it up for answers and questions. While we'll have Q&A at the end of the session, please feel free to also drop them in the question and answer box, and we will try to get to as many of them as possible. We also have an FAQ document on our website along with the grant guidelines. We'll continue to update that FAQ document as we get additional questions for the program. Let me talk a little bit about the foundation before we get into the meat of our conversation. The foundation has three focus areas: coverage and care, structural racism and racial inequality in health, and behavioral health. I will not go through each of those programs, but I will direct you to our website if you want to find out more. The focus of this particular program fits into our behavioral health portfolio. We also have, as I mentioned, three program partners, two of whom are here today and will be speaking, and one who will not be speaking. And that one not speaking and not here today is Institute for Community Health, which is a nonprofit consulting organization that provides participatory evaluation, applied research, assessment, planning, and data services. And then we'll also hear from Partners in Health, who is a social justice organization that responds to the moral imperative to provide high-quality healthcare globally to those in need of it most, and works both in Massachusetts and around the world. And finally, we'll hear from the Family Van, which supports communities by increasing access to health care and improving health for residents in Boston, most underserved communities. So let me talk a little bit about the program. On the next slide, please, Evelyn. So why are we doing this? And so one of the things we know is that access to behavioral health services continue to be a significant challenge in Massachusetts. We all know that there's a behavioral health workforce shortage, and at the same time, there is an increased need for behavioral health services, amplifying the need for more behavioral health professionals. In addition, there's a desperate need to increase the linguistic, cultural, and racial diversity of the behavioral health workforce to better meet the needs of those seeking care. As long-term solutions to address the behavioral health clinical workforce shortages are developed, it is critical for us to expand our view of the role that trained non-clinical individuals can play in meeting the basic health needs of individuals. There's an evidence-based practices that have been primarily implemented in low-resource countries that we can adopt here in Massachusetts to expand access to mental health services. These programs are often referred to as low-intensity psychological interventions. They can be delivered by community members who have been trained to deliver basic mental health services without the intensive training that is required for individuals traditionally considered to be a part of the clinical behavioral health workforce. Next slide, Evelyn. So what are the goals of this program? The Advancing Community-Driven Mental Health Program has two goals: to improve and increase access to community-based mental health for individuals experiencing mild to moderate mental health distress and practical problems of daily living, and to develop the skills of a non-clinical workforce to support community members in addressing mild to moderate mental health distress and problems of daily living. So what is PM Plus? We will hear about the key elements of PM Plus intervention from Dr. Stephanie Smith, and then they'll also discuss lessons learned from implementing PM Plus around the world. So next slide, please, Evelyn, to the what is Problem Management Plus, and let me turn it over to Dr. Stephanie Smith. Next slide.
Thank you. Thanks, Jackie. So I'm Stephanie Smith, as Jackie said. I'm a psychiatrist. I co-direct the mental health program, the cross-site mental health program at Partners in Health. And I'm going to tell you a little bit about Problem Management Plus and what we do at Partners in Health with Problem Management Plus. So as Jackie mentioned, this is it's called a low intensity psychotherapeutic intervention. For those with mental health backgrounds who are listening, this is a WHO developed intervention that's based on cognitive behavioral therapy, but it really focuses on the behavioral and problem-solving aspects of CBT. So this was designed probably about over 10 years ago with the idea that it could be adapted for non-specialist providers to deliver for adults living with distress in all sorts of settings across the globe. So it is considered a trans-diagnostic intervention. So it is helpful for people who have been diagnosed with depression, anxiety, and stress and other mental health problems, but it also is meant to support people who don't carry a diagnosis or don't need a diagnosis with the problems of daily living and the other stress in their lives. Next slide. So there are 4 core strategies across the intervention. The first is stress and anxiety management, relaxation techniques. The second is managing problems. The third is a type of behavioral activation intervention called Get Going, Keep Doing. And then the last is strengthening social support. So you have 4 main psychological strategies within this overall intervention that usually also includes an intake and kind of a final wrap-up session. So next slide. So we have been at Partners in Health, we've been working with Problem Management Plus since about 2016, close to when the World Health Organization first published the intervention. And at that point, we adapted it for use in Rwanda as part of our larger health system strengthening efforts within the public sector to include improved care for people with depression and anxiety. And after that, we adapted it for use in Peru and Malawi and Lesotho, and then in the USA, including supporting the family van starting around 2018-19, who you'll hear from right now. And then with this ACDMH initiative, which we're discussing today. And the settings in which we, as Partners in Health, deliver Problem Management Plus are varied, from government-run primary care centers to communities outside of the health system altogether. We've had both non-specialists and people with mental health backgrounds deliver the intervention, and we found that the feasibility and acceptability of PM Plus across these varied settings to be high. And as an organization, we've also focused on developing the technical and operational guidance for delivering PM Plus in a variety of settings, since delivering the intervention is much more than just adapting the manual that's published by the WHO to context. And we've had success in creating a kind of rubric or blueprint for the delivery of mental health interventions, whether PM Plus or other, including especially a focus on effective supervision and support of the non-specialist providers, which is a critical element when you're delivering PM Plus. So all in all, across our PIH sites, we've had almost 7,000 people receive PM Plus, and we're currently looking at adapting for other of our country sites and supporting others as well through this initiative. And I will stop there and hand it over to Raynell to tell you about the family van.
Good morning, and thank you, Stephanie, so much. My name is Raynell Walker-White. I am the Associate Director of Health Equity Program at the Family Van and a community health worker working in the community, helping the clients to become better at the problems and the situations that they may be facing. So can we have the next slide, please, Evelyn? When you think about the lessons learned through the ACDMH and the cohort that the Family Van has started, we actually learned our training. We had the training through PIH. And when you think about it, we're just thinking about how the community comes together. The Family Van is been in the community for over 33 years, actually. And we have been providing these services to the community. We are reaching people where they're at, and we're doing a lot of outreach that would not be done by any other institution or program. And when you think about us doing the PM Plus adaptation, and I'm so sorry because this slide was not in my actual presentation, but I'm actually going to be just going based on what you have here. And so when you think about it, the Family Van has adapted a lot of the different trainings. And what we did was we had to tweak a lot of the things that we started with because PM Plus in different continents in different countries did not help the clients where we were. So we wanted to make sure that the work that we did was culturally competent. The language that we provided was going to be feasible, and the way that we delivered the services were going to be adapted to our clients. We personalized it, and we were able to really meet the clients where they are. And Healthy Roads is an entry point to the mental health support. When you think about the people that we're serving, the communities that we're serving, everybody is going through something. There are challenges in everyone's life, and we know that we're a trusted entity as we are in the communities that we are serving, and people come to us and they know that through the work and the tools that we are giving them, it's an opportunity for them to come back and for them to trust us to get to the next stage of their development in their mental health challenges. Next slide, please. When you think about the results and the lessons learned, we have the statistics to really show the improvements in the mental health and the outcomes that we have exhibited and seen. A lot of the depression symptoms of our clients have really declined. When you think about it on a day-to-day basis, there may be one thing that we need to address that really has been a challenge in somebody's life. That one thing that you address is allowing them to be able to move forward, to be able to have better outcomes and improve their dealings with their family, their environment, their social entities. And as we are working alongside of them, we're seeing that we as providers are changing. We have more patience, we have more empathy, and we're doing this because we are in their lives on a day-to-day basis. We see them in a different realm than the psychologist or the social worker because we are walking alongside of them and we're helping them. As we are growing in our work, we're also seeing that we're becoming more comfortable in our skills and the way that we are dealing and working alongside of people. PM Plus program has really been a dynamic aspect, and I can definitely say it has changed a lot of people's lives. I have worked with many people that say that one session alone has allowed them to get to where they needed to get to be able to face the daily challenges on a day-to-day basis. Participant recruitment has been challenged. You know that outreach is important, and as we are working in the communities, we are there. We're meeting them where they are. They come aboard the Family Van for any aspect of the services that we provide, but then we're able to connect them to the other services that will allow them to really engage in some of the changes and the growth that is allowing them to do what they need to do. Next slide, please. why did we choose ACDMH and PM Plus? You know, when you think about it, you know, the staff that I have under me working alongside of Jackie and Stephanie and PIH,
Up to
we
a
really
second
have,
there, because I know, so you have two things. You can talk about why the family van decided to do PM Plus, and then I want to turn it over to Rachel, who will talk about CEOC's experience. So why don't you
okay.
just do why the family van chose PM Plus, and then we'll turn it over to Rachel.
Why did we choose it? It's because the community health workers that we work with are trained and educated in working with people on one-on-one. And we were just hearing in our community that a lot of the people really needed somebody to walk alongside of them. And with our expertise in the work that we do in partnering with PM Plus, it was just a win-win for everyone. So I'll stop there.
Thanks, Raynell. Hi, everyone. I'm Rachel Plummer. I'm the Associate Director at Cambridge Economic Opportunity Committee, or CEOC. We're an anti-poverty community action nonprofit in Cambridge, Massachusetts, and we were part of this first cohort of ACDMH. And the reason that we chose to participate in this cohort primarily was because of our staff champion. So we have a staff person here who has been talking about mental health for her community for many years before we even knew about PM Plus. She is bicultural. She's from Ethiopia and has a lot of connection to the Ethiopian community in Cambridge, and was noticing all of these mental health challenges in her community and a lot of barriers to seeking care. And so, number one, the language barrier. It's hard enough to find mental health care in English, and it's near impossible to find it in Amharic, which is the language that many of her community members speak. And then also the stigma barriers. The words mental health, depression, anxiety are very taboo in a lot of different cultures, including for American-born folks. And so this was a really attractive program because it would break down a lot of those barriers. So it gave us the ability to train our multilingual staff to deliver this intervention and to tailor it and adapt it in a way that was going to give folks the skills that they need without calling it mental health, without calling it a depression or anxiety program. And so that staff champion was kind of the spark for looking into the program, and the ability to adapt it in a way that was culturally relevant and meaningful for our communities was what kept us pursuing it. We were also really impressed by the level of technical assistance and support that was going to be provided through the grant program. And because we are not clinicians, we needed a lot of training, support, and guidance. And it's an intensive program adaptation and training process. And so we felt really confident in the support that was being provided and all of the experts that were involved in the program. And then lastly was just the skill building for staff. We're always looking for opportunities to empower our staff with new skills. And so this was folks learning a new program and also being empowered with skills that were going to help them beyond just the PM Plus, would also be helping them just relate better to their clients for our other programs. Next slide, please. And so how does PM Plus look at CEOC? We call it Journey to Hope at our agency. And sort of like I mentioned, it has allowed our staff to have these skills in active listening, in mental health first aid, and in coaching that are really transferable to all of our other programs. And so the program has had a big impact on our clients and also our staff, feeling more confident to be able to support clients. We have a lot of different social services that we offer, helping people with SNAP, health insurance, and oftentimes, we just want to do things as quickly as possible, do things for the client. And this has really allowed us to shift our mindset to think more about how do we empower clients, coach them so that they're set up for success after they stop engaging with our agency. It's allowed us to connect with clients and give them support that they wouldn't have sought otherwise. So again, with the stigma piece, the staff have had these long-term relationships with a lot of clients, and that trust building that they've already done has helped us be able to provide this mental health support, even for clients who have so much stigma surrounding seeking help in general and around mental health specifically. And then lastly, there's been so many positive outcomes for the clients who have gone through Journey to Hope. And it sounds like a short program, which it is. It's just 5 sessions, but we've had folks who were living in a shelter for 10 months by the end of the program get into their own 1-bedroom apartment. We've had people who had been out of the workforce for several years get a full-time 9-to-5 job. And so it's having real mobility impacts in addition to just the mental health support that it's providing. So I'll stop there and pass it back to Jackie.
Thanks very much, Rachel. And can we have the next slide, please? So we're going to talk now about the key program elements and support. Next slide, Evelyn. And so there are 3 real program elements that I want to talk about and the supports that's provided. So we have a technical assistance from the Family Van and Partners in Health. Both organizations work together to provide coaching to adapt the PM Plus manual, organize learning collaboratives, provide office hours for the PM Plus providers, and conduct the PM Plus core skills training. And they also conduct clinical supervision meetings with the clinical supervisors to help the clinical supervisors support the PM Plus providers. We have the evaluation component, which is ICA, Institute for Community Health. We did not get to meet them today, but they're a critical part of this program team as well. One of the key activities for ICH is to support the funded organization in developing systems for robust process and outcomes evaluation during the program implementation. They also provide feedback and actionable information throughout the program to facilitate real-time learning and identify opportunities for TA and supports that will shape the program implementation. So you also see organizational preparedness, manual adoption, outreach and recruitment. This is all the kind of supports that you will get, the funded organization will be provided for from our technical assistance providers, PM Plus and Partners in Health. Outreach and recruitment, intervention, clinical supervision, learning collaborative. Those are all a part of the core pieces of this program. Next slide, Evelyn. So let's talk a little bit about organizational readiness. On our website, you will see a document that's called Organizational Readiness Assessment. We ask that you review that assessment on the website to determine your organization's readiness to implement Problem Management Plus and to participate in the Advancing Community-Driven Mental Health Program. This readiness assessment will also be an eligibility question before you're able to fill out the application. We're not asking you to physically or write the answers, but we need you to review it to have an understanding of what the elements are that the organization will need to be prepared to do for this program. And so the goal of the assessment is to assist you to understand the commitments, capacities, resources, and partners needed to implement PM Plus. Your decision about whether to proceed will be based on your organization's capacity to meet some of the program requirements, including identifying 6 to 8 frontline staff to train for PM Plus, participate in a mental health first aid training for staff members who will be interacting with the program in addition to the providers, participate in 5 days of PM Plus training, adapt the manual to be culturally relevant to your organization and the population you serve, and integrate problem management integrate the program into the organizational structure and workflow. So those are some of the key elements that are critical for the organization to participate in this program and to be successful in participating. Next slide, Evelyn. Eligibility criteria. 501 Foundation will only consider organizations that meet the following criteria: 501c3, nonprofit organizations that primarily serve people who have been socially, economically, and racially marginalized, community-based non-clinical organizations that provide direct social or community-based services to individuals and families, community-based organizations with a strong, trusting relationship with their community members, and cultural and linguistic ability to connect with the populations they serve, and community organizations whose staff are reflective of their service population. So those are the eligibility criteria. Now let's talk about the timeline. So we have applicant webinars today. The portal, the grant making portal will open later on today. The reality is you have all the information you need on the website already. The grant, the letter of interest with the questions, the FAQ, and the readiness assessment. I always recommend that people work on their proposal offline prior to then uploading it or to putting it in the document into the portal. There will be Zoom office hours between July 2nd and July 17th. And that information is both in the letter of interest and it's also on our website. You can just sign up for one of those sessions, pop in and ask a question. We'll have individuals, you'll be in a waiting room and I'll admit individuals to ask their questions as we move forward. The proposal deadline is July 24th by 12 noon. No, there will be no technical assistance after 12 noon on July 24th. End of August, we'll notify those who are going to invite to submit a full proposal. We're inviting 12 organizations to submit a full proposal. We will have, the full proposals will be due by September 26th. There will be virtual site visits between the 14th and the 17th of October. And then the grants will be awarded at the end of December. And the program launches at the beginning of January 2026. So that's the timeline. Those are some of the, the key elements of the program. And so I'm gonna ask Evelyn to stop sharing the slides and we'll respond to some of the questions that we haven't responded to at this point. Rena, any?
Just a couple that were particular to our speakers that we want to tackle was there was a question if the organization's Family Van, I think, and Cambridge Economic Council, if you could talk more about your outreach strategies, what you used, maybe if you could talk a little bit more about what you found helpful, maybe what was a challenge or what you didn't find helpful.
Sure, I can talk a little bit about the Family Van and what we did. Because we are a mobile unit and we are in the community and we are seeing people on a regular basis, the outreach that we did was designing some cultural, linguistic flyers and pamphlets. We put it out in the community everywhere that we went. Even as we did outreach with our own information, we would share that as well. We would talk to the people in the community. We did special events in our communities as well, where you do family days, where it's an opportunity for you to see a whole complete family, and you are basically just giving information out that way. You always want to just make sure that the information that you're giving is accessible. People can read it. There's different languages that people speak. You want to make sure that your staff is able to speak to them in the different languages as well, because if you can't meet people where they're at, you're not able to take care of them. Hope that answers your question.
And I'll add too, for CEOC, very similar approach to what Raynell mentioned. We offer most of our services in an office, and it's a multi-service agency. So our first point of outreach was training even the staff who didn't deliver PM Plus. We gave them a training on how to talk about PM Plus with clients, so that anyone coming through our door for a program like health insurance or SNAP would also be introduced to PM Plus. We also did information sessions with other providers. I think because of the stigma issue, this program can be kind of tricky to talk about or advertise for in a general way. So we wanted to meet with other providers at similar organizations or public housing developments to explain the program to them so that they could use their relationships with folks to introduce it and refer people over to us. And then at our, traditional outreach events that we do for all of the services at CEOC, we always try to highlight PM Plus.
Thanks. Rachel, while we have you, I know you answered it in the chat, but I think everybody might like to hear it. Talk about some of the examples of guidance and support given to your organization as you went through the training.
Yeah, definitely. So through, I know that the timeline is a little bit different for this cohort, but through the planning year, we had monthly calls as a cohort. So led by Partners in Health, the Family Van, the Foundation, and ICH, all of the community-based organizations would come together and there would be a new topic or training each month. And in addition to that, we had one-on-one, either monthly or every other month calls with the technical assistance team. And what I found was really helpful, the WHO manual is several hundred pages long and it's overwhelming to look at that. But the TA team put together a Google Doc version of a manual that could be adapted by us that was much easier to digest. And they indicated exactly which sections were going to be the most modifiable or suggestions for, in this session, we did it this way, other groups have done it this way. So it was just like very hands-on support with learning the intervention and then adapting it for our context.
Thanks, Rachel. Jackie, there's a fair amount of questions around the criteria and eligibility around the kinds of organizations. Do you want to just spend a few more minutes diving into that? And then we have specific questions around FQHCs and whether they're eligible.
Yes, certainly. And I'll also refer folks to the FAQs once the webinar is finished. The eligibility criteria is community-based organizations. As a reminder, we are trying to expand the behavioral health workforce. This program is to train non-clinical individuals to provide support to people. And so that means that we're not prioritizing and we will not be funding hospitals, community health centers, community-based mental health providers. They can partner with a community-based organization because in each of our, the clinical supervision is a critical part of this program. So all the grant partners that we presently have, they are connected to a clinical supervisor, whether it is they have a clinical supervisor in their organization or they have subcontracted with a clinical supervisor. And maybe Rachel, in a minute, you can talk about how you got, let me stop now and say, how did you guys do your clinical supervision?
Yeah, sure. Yeah, so we don't have any clinical staff at CEOC. So we historically had partnered with another community-based organization in Cambridge called De Novo, which is a legal services and counseling organization. And so we had worked with them on other projects and had a relationship with them. And their clinical director is providing our clinical supervision. So she's not housed within CEOC, but is part of this project. And we contract with their organization and use funds from the ACDMH project to reimburse her for those services.
Rachel. And I would say, in addition, a couple of the organization had clinicians in-house that they used to provide clinical supervision for the program. So an organization can have a clinical component to it, but you need to be focused on the non-clinical providers in the organization. So we're looking at training frontline staff, the staff people that are at the front desk when people come into your front doors. Those that Rachel said are providing SNAP information, they're providing tax credit information. Those are the folks we want to train, because that focus is on training non-clinical people. So not even bachelors of social work, non-clinical people to participate in this intervention. And one of the things you'll see in the FAQ is there's so many different kinds of organizational structures that if you have a specific question, I would encourage you to sign up for one of the office hours, and we can talk about your specific situation at that point in time.
Thanks, Jackie. We have a question about the metrics used to assess the outcomes and a required minimum participant. So I think it's maybe somebody wants to talk about the metrics used, and maybe we can dive, if anybody wants to talk about the evaluation and how that is all linked together. I don't know if PIH wants to take that, or
I
Rachel?
can talk about the metrics a little bit. You know, in general, you know, certainly the initial research projects that developed the evidence for Problem Management Plus used very standard depression metrics and disability. So they used the PHQ-9. For those of you who know, it's a depression scale, and others. One is focused on the problems that people bring to the intervention, called the Cyclops. So that has been a part of the evaluation, the research, the research evidence, and then also the evaluation during the first cohort was using those metrics. I'm not sure that we have discussed exactly what if they'll be the same metrics or additional or different metrics for the second, but usually if you're looking at a quantitative scale, it has to do with depression symptoms or psychological distress, or something that has to do with the specific problems that people bring to the intervention, and whether they would, self-rate it as having improved. So overall, those are kind of the realm in which we're talking about the quantitative metrics. And then there's qualitative, and people give many different types of responses on how it's helpful for their lives qualitatively. I'll let Jackie answer about the numbers, because I think that was a two-part question.
Yeah, and so what we're looking at, the minimum number of clients that we would like each program to see by the end of the grant period, which is by the end of the 2 years, is 70. So that's a minimum number. And yeah, so 70 individuals, 70 clients that finish the full 5-series session. Now we know that, clients will sometimes start and then stop because life happens. And so we totally understand that, but we'd like to see, that number achieved by the end of the 2 years.
Great. Another question we have from a couple of folks is around the number of staff trained in PM Plus. So I think we believe we say 6. People are wondering if that's a hard number. Is there any flexibility around that?
Pretty hard. And the reason why we did that is because you're going to have staff turnover, and you're going to be constantly training people. So the larger the number you start at, the better it is. So you're not always training, because I think we started in this first cohort with training three people in an organization. And then some organization had staff turnover. And so we thought the best to have train more. And so we account for that staff turnover early on in the process, as opposed to later on.
Great. We have another question, just actually a great question. The program model looks very interesting, but the slides and speakers all feature women. Is there anything in the grant guidelines and program model that focuses on men or allows and encourages male involvement? Anybody want to talk about what your client population looks like?
Yeah, you just happen to have all women, but I will say, and then I'll turn it over.
I can talk about our population. We definitely see more men on our mobile unit, then we see women because men are really not wanting to go to clinics or hospitals to be seen. So we do have staff that do work alongside of the men, and it's a great opportunity for them to really, share some of the problems and some of their experiences around mental health and why they don't seek the help that they can get. But being on the family van, it's almost like coming into somebody's living room. It's a totally different environment, so it's very welcoming. But we do see a lot of men, and a lot of men really do share at that time. And Rachel, I'm pretty sure you could speak on it as well.
Yeah, I think we at CEOC we see probably more women than men. I think for PM Plus it's 60 to 70% women for our population. And our providers are all women. And one thing that we were kind of going back and forth on as we were thinking about training new providers, the stigma looks different for men versus women, I think. And we were talking to folks to decide, is that stigma going to be stronger if the provider is also a man? I think we had heard feedback that some of our male participants were more comfortable speaking with a woman. So I think it just really depends on the community context. And that would definitely be something that you'd want to think through as you're adapting the manual. The manual itself is very not tailored to a specific gender. And so as you're thinking about maybe outreach approaches, that's something you'd want to consider.
I would also add from the full evaluation of the first cohort, majority of the people, the clients seen have been women. That's not to say we wouldn't love to see an increase in men in men participating, and I think that's the outreach. And if an organization, that's just the outreach, and who have the individuals who have participate in the program. And I actually don't think it's any different from a general population of who reaches out for mental health services. It tends to be women, I would think, and who provides the services tend to be women. So I just, it kind of mirrors the larger population as a whole.
Thank you. We have addressed, there were some questions about the age for this program to receive the PM Plus services, which we said 18 plus. We have another question kind of going a little bit deeper on that. We have an organization that sees young adults 14 to 24. Would PM Plus be appropriate for the younger participants? Mary, I'm going to say with your 18 to 24 population, and you're wondering more clearly about that younger demographic of adults. So can PIH or somebody speak to that?
Yeah, I think the evidence of this established with adults. I do think that there are some efforts globally to deliver in younger populations and adapt some of it for younger populations, thinking about life skills and such. So it's not that the skills themselves would be irrelevant to the younger population, but I think if we're keeping in line with what the global evidence has produced around efficacy and effectiveness, then we would keep it with adults for now, because this is an implementation program. It's not meant to, be generating new evidence around these interventions with teenagers, for example.
Thank you. There's another question about, Edward asked, can non-cash incentives be part of the funded elements? Edward, I'm going to assume you're meaning for the participants to participate for the participants as they go through the process. Have we dealt with this before?
We have certainly been thinking about this as a part of the recruitment outreach strategy. And I don't know if any of the present cohorts have done that, but I think folks have talked about it. And it's something I think we would certainly be open to having conversations about. What do you think, Stephanie?
In our other country sites, some places have provided refreshments, paid for transport, and I mean, I think some of the organizations have done a little bit of swag in terms of recruitment, like mugs and other things. I think, you know, you have to weigh all of the benefits and drawbacks of that within your own organization, and what that means. But I don't see anything like fundamentally a problem with having somebody, you know, get a mug or a t-shirt or whatever it is that we would do for recruitment.
Are you doing something specific, Rachel, at COC?
We don't have participation incentives. We just have like branded outreach materials like CEOC stress balls and stuff to draw people in, but not yeah, nothing more than that.
Sometimes people actually really like getting a certificate when they finish. So that is something to think about too, which wouldn't have to be much funding.
Yeah, we also give out breathing rocks that says breathe on it when we do our sessions. And yeah, we give out certificates as well. Then we do send you know, even birthday cards or just some, you know, thinking about you cards throughout the session as well, just to let them know that we haven't forgot them, especially if we can't get in touch with them. Because as Jackie mentioned earlier, life happens. Sometimes people move, things happen, so you want to make sure that you stay connected to them.
There's a question about an eligible community organization. Could they work with an academic partner on this grant? That might be something we want to dive in one-on-one, but
Can you say the question, an eligible?
could an eligible community organization work with an academic partner on this grant? Ling Ling, if you want to maybe type a little bit more about what you mean, then we can tackle it. If not, I would encourage folks. There's a lot of eligibility questions in here that I think people want to dive into. So I'm going to just and I'll post it again. But if you go to the website, you can set up a time and dive into some of this with Jackie. But Ling Ling, if you want to say a little bit more, if you want to type in another comment, we can try to dive into that. Jackie, there is a question about whether municipalities are eligible. That might be one to dive in one-on-one so we understand where within the municipality folks are talking about, or
Yeah, just remember, we're trying to train not frontline staff. You have to have a client population that you are serving. You have to have enough people coming into your organization to increase the likelihood of take-up of the program. So those are some key elements. And yeah, in terms of municipality, it can't really, I would need to know more. What does that mean? What does that look like?
going back to the academic partner question. Thanks, Ling Ling, for expanding. Yes, they're wondering, could a community-based organization essentially partner with an academic organization where they would work together on the grant application and implementing the program together? That might be another where we would have to understand more about what you were looking to do.
Yeah, I don't see a problem with, there's no problem with partnering with organizations. Understand the grant amount is $100,000, up to $100,000. And so, yeah. So if wanting to discuss further, please feel free to set up an office time.
For folks asking
And
if we'll share the slide deck. Oh, sorry, Jackie, go ahead.
Yes, the slide deck will be shared, and I just wanted to iterate something I'd actually put in answer to a question. Clinical supervision is an important part, and a clinical referral pathway is a key part of this program. So it's not just a community-based organization. It's a community-based organization, either has a clinical supervisor inside, or they are partnering with a clinician or whether it's a community health center, some other entity that's providing clinical supervision.
Can I answer the question about the staff trained? Will the staff have the ability to train others? So I think I answered something similar in the chat that we we don't provide a formal train the trainers so that it's like about how do you then teach other people, but you would go through the training, and then we do have a kind of a template for you to think about your own, developing your own training, where you include the important elements that we include in our kind of build up to delivering the intervention. And, just remember, in general, Problem Management Plus is an open access intervention. So there's not any kind of patent or something that says that you can't just take the intervention and figure out how to deliver it yourself. There's not like a stopgap, like you have to have done this thing or that thing in order to be able to deliver the intervention. It's published by the World Health Organization and it's open access. So what we have done is made it more accessible, I think, and we provide a lot of help and support in thinking about how do you see a program through from very beginning to end. So yes, I would say that, if you have people who are interested and willing and able and desiring to become a part of an organization to keep moving it on and be able to train, that is critical for sustaining into the future, is that you have in-house people who can take that on. So I would imagine that if you have motivated people throughout, that you would be able to do that by the end. And Rachel, you can also perhaps speak to that.
Yeah, just to say, all of the organizations in my cohort, I think, have now trained additional staff, and I think for some organizations, staff turnover was an issue at the beginning. And so, yeah, all of the materials from the training that the original providers went through, slides, videos, all of that was all made available to us. So we kind of used those materials, as well as some like discussion and role plays internally, to create a training for newer staff.
There was a question, I think it got answered in the chat, but it might just be helpful to dive into. Could we spend a little bit more time on the role of the clinical supervisor and their role, like, in what role do they play in the actual PM Plus training as well? Could we walk through that again?
Stephanie, could you take that?
Yeah, so we for non-specialist providers to deliver an intervention like PM Plus, even though the skills are learnable, the actual delivery of it and engagement with people in this space, in the mental health space, takes support and ongoing discussion around cases. How do you think about the individual who you're working with? Also thinking about, do people need kind of a higher level of care, or is there something else going on that we need to kind of move them away from PM Plus into some other formal mental health care delivery system? And so that's a lot of the role of the supervisor. So we have in the past always encouraged and I guess required the supervisors to participate in the initial training, not so much because they need to learn the skills. They probably already have the requisite skills if they are a licensed clinical social worker or a psychologist, but it's good to learn what the providers are learning, and then to be able to build the rapport with them, and then figure out a system where you can support them in delivering the intervention. So, if a supervisor could not participate and there was some specific circumstance, then we could potentially discuss. But in general, that's what we like to see. In order for them to really, it is a bit different to support non-specialist providers than to support like trainees in your own field.
Thanks, Stephanie.
Mm-hmm.
Rachel, I think do we have time for one more, Jackie?
We have, time for a couple more.
Okay, so Rachel, I see you're probably getting back to Kate, but this might be a good one just to address in the group. In the manual, I read that clinical staff that are going to do the trainings should have 40 hours of training on the curriculum. However, if there is no training specifically for the trainings, how would that learning be structured? Do you want to share your answer with the group, Rachel, that you're working on?
Yeah, I can chime in. Thanks. So I think what Stephanie was saying is that we don't provide a training of trainers model, which is a specific type of training to train the implementers to then train others. But what we do provide is this core skills training, which is what you're asking about, for those who are facilitating and actually providing the intervention, but there just isn't an additional training on how to teach others how to do it. But ourselves, PIH, the family van as well, alongside BCBS, we do provide this training for the 6 to 8 providers from each organization on the curriculum and how to implement in your own setting. So just wanted to clarify.
Yeah, you might be reading that, Kate, in the WHO manual. You know, they have a lot of guidance and around, you know, if you're going to do PM Plus on your own. And so if you're having a staff who are going to do, you know, who are going to go do PM Plus trainings for somebody else, you know, ideally they will have actually done PM Plus or read the, you know, that they don't just kind of de novo take it and try to do it. I think that's what they're saying. But I don't know what part of the manual or what you're looking at specifically.
You know, I'm conscious of time, and I know there could be many other questions that that folks have. And so I will encourage you to sign up for one of the office hours, particularly as it relates to eligibility. Specifically, look at the frequently asked questions. And I will also encourage you to look at the organizational readiness assessment to ensure that your organization would be in a place to effectively implement the program so you're successful. So I just want to thank you all for participating in this call, and I want to thank Rachel Plummer from CEOC, Dr. Stephanie Smith from PIH, and Rachel Isaac from Partners in Health, and Renelle Walker-White from the Family Van. You know, all the folks here have been a really critical part of the program, and I think, you know, the feedback the foundation have gotten from all the grant partners is that this has been a really effective program to not only help clients, but to help strengthen organizations and individuals in this program. So I want to thank you guys all, and Rena and Evelyn, thank you for your help. And so thank you all, and we will continue to update the frequently asked questions, and also add any please sign up for the office hours. So thank you all, and have a good rest of the week.
Thank you.